Hello, my name's Seena Fazel. I'm the director for the Centre of Suicide Research here in Oxford and a professor of forensic psychiatry. I'm going to give a presentation today about two or three issues which are, I think, quite hot topics in the field of suicide research and suicide prevention. Um, and they revolve around whether suicide can be predicted. Um, and recently I've been to a number of events and conferences where this has been discussed quite widely. And I thought it would be quite useful just to address what I think are some myths and introduce some new research, particularly by our group, on that speaks to this question. So I'm going to talk about some outdated criticisms, move on to some new methods to address this question, and then look at a couple of models that we've developed, really just by way of examples, and leave it at the end with really raise some questions about implications rather than make any strong suggestions about implications. So I want to start off with the myths, and I'm going to highlight five. And this is the one that's often repeated, is that when you classify people into high and low risk, that's basically too inaccurate, based on tools that have been developed so far to be useful. And I think it's a myth, mainly because you don't always have to use classification. And I'll give you an example how it's done differently. So this is the BBC weather app. We all use different apps for weather. But as you can see, it doesn't say a high or low category for rain. It gives a percentage score. This is a probability score. And actually, most of the models being developed in medicine last decade use probability scores. They don't say yes or no. So here, for instance, even if you decide to use a cutoff, let's say your cutoff is, in this case, 30%. This is today's weather in Oxford, actually. Then you have between 3 p.m. to 5 p.m. An elevated risk of rain if you want to use a cutoff of 30%. You may decide to use a cutoff of 50% or 70% or 100%. But the point being is that your cutoff, if you use it, inherently has the error value in the score. So if it's 36%, you know that days like today, 64 days rather, if it's 36%, 64 days like today, it won't rain at 3 o'clock. 36 days like today, it will. And that's very different. It's not yes, no. It's not saying yes, definitely rain, no, not definitely rain. It's giving you a probability. It's bringing in large amounts of data in a way that is much more usable, much more flexible. And I think that's one of the main issues in this whole area, is that the whole debate revolves around old ways of doing this, which are to use a cutoff score, where if you score above a certain cutoff, people test it against a outcome of suicide. So, I mean, this has been made. So one of the fathers of statistics, Frank Harrell, writes in his blog that he doesn't want to know whether it'll rain today, yes or no. He wants to know what the probability is. And he says that this applies also in credit risk scoring, in prognosis, in diagnosis. He's saying, really for these type of decisions, you want to have a probability score, not a classification measure, yes, no. That's just not credible, particularly with large amounts of data. You want to know the model tendencies, probabilities, and that fits in with the way decision making and across the whole range of medicine is done, and also beyond medicine. And this is again made by various other researchers. So Richard Riley is Professor of Statistics in Oxford, and he actually works quite a lot on prognostic models in a variety of different areas of medicine, and one of the leading methodologists in this area. And then, he also makes the point is that prediction models should present risk estimates, probability scores, and he points out that many clinical researchers push for this classification yes, no, a binary division, and it doesn't have to be like that. it doesn't make any sense to do it like that, because if you want to use a cutoff, that will vary depending on what decision you're making and the setting you're making it and the implications of that decision. Another example of that is the Q risk. So this is a very widely used cardiovascular risk calculator. It's used in the UK. And around the world, there are variations of this, like the Framingham score, which is probably the most successful prognostic model in medicine, which does a very similar thing, a 10-year risk of a heart attack or stroke. And here you have a percentage, 1%. This is someone who lives actually in this area, a 40-year-old woman with few background risk factors. And it really means that this person, well, someone like this person in the next 10 years with the same background risk factors has a 1% chance of experiencing one of these outcomes. And equally is another person who lives in this area with more background risk factors, an older man, and here we have a much higher score of 18%. And that's quite important. I mean, it's saying that this individual would probably benefit, almost certainly will benefit from some lifestyle changes, dietary changes, and should definitely consider taking a statin, because we know that a statin can reduce the risk of this over the next 10 years quite substantially, with few side effects, if any. And this particular way of tackling this issue about someone's prognostic risk for heart disease is one that we've been trying to work towards in developing for suicide outcomes, and I think one which the field hasn't really captured. This is the way of doing it. So these models are not tested using classification measures like positive predictive value, because there isn't a positive predictive value here. Here you have, even if you have a cutoff of 10%, let's say above 10%, you should consider using a statin or making lifestyle changes or dietary changes. This percentage score has inherently its error rate locked into it. So you know that we're talking about 82 people like this individual who won't experience that. And on the basis of that, you can make a decision, and guidelines can then be formulated to inform that. So, which brings me to positive predictive value, because this is something that people often talk about, that the positive predictive values are too low in the field of suicide risk prediction using the tools that currently exist, and they will always be too low, so low that they become actually useless. But of course that's not relevant if you use a probability score. So the positive predictive value assumes that someone above a certain cutoff, let's say you have a tool that has a score between 0 and 50, and then you use a cutoff. Let's say the cutoff is 10 out of 50 for this tool, it's this checklist. And then the people who score above 10 are followed up for suicide outcomes. And then people say, well, look, it doesn't do very well. Based on the people who score above 10, how many of them die from suicide? So the positive predictive value is testing the people who score above a certain threshold against the outcome, which is suicide. So how well does it sort of predict going forward? And that, of course, is not relevant for a tool that uses probability scores. It's also problematic because it depends on the outcome prevalence and the cutoff, and you can change those. So even the criticisms of PPV, I think themselves are not actually very nuanced, because you can change the cutoff and you can change the positive predictive value. And also there isn't such a thing as a one PPV. It will depend on the clinical context. But I think my main point is that it's not appropriate for models that use probability scores, and it shouldn't therefore be the metric or the performance measure or the statistical test that matters to clinicians, because actually it's not relevant for the new models in the field of suicide research. Which brings me to the second myth, I think, which is partly related to this, which is that stratifying risk, and stratifying risk means separating out into groups, has no role in suicide risk, and really we should just be treating everyone the same. And that's partly because people say, well, stratification is very difficult to do, and partly because actually it doesn't really add any value to treating everyone the same. So there's various things to raise in relation to this. I think at this point what I'll do is just talk about whether it has no role at all. And I'll give an example of a paper that was developed using data across Oxford, Manchester and Derby, where they followed up all the self-harm admissions to hospital for death from suicide. And the things I've highlighted are relevant insofar as you can see the role of risk stratification using two very basic factors, age and sex. So we have, in this particular study, 20,000 women or so who presented with self-harm who are aged between 15 and 24. And they and we also had 2,766 men over the age of 55. And then if you follow them up for the next year, the number of men that died was 29, and the number of women that died in that particular population was 14. So you have two factors, and if you calculate the rates, which is the first column here, the 1,873 is the incidence rate in the men versus 118. I mean, that's an 18-fold-ish difference in rates. So based on two factors, you have an 18-fold difference in subsequent risk of suicide. So you can see that stratification according to age and sex does have a role. It has a role, it does identify higher risk groups. And the idea that you would do things differently for men over the age of 55 and who present with self-harm versus women aged 15 to 24 is one I would question, because I think you would actually be much more clinically careful in terms of the assessments and the follow-up for someone who's over the age of 55 who presents as a man to hospital with self-harm. Here's another example. So here's those are two factors, but I mean my point really with this slide is quite busy, but it shows a number of other factors, including other diagnostic diagnoses like substance misuse, what treatment people had, which is a proxy for mental health problems more generally, their history of self-harm, and the current, some measures of the current episode, like whether they were admitted overnight or not. And if you put them all together in a model, adjusting for each other, these retain some value, I think, in terms of risk stratification. So here, the point is that you can increase the number of variables, and it can give you even better stratification by according to these background characteristics. Another myth is that you can't predict suicide. So people say, well, if you use tools, they perform very poorly on classification measures like positive predictive value. Then people say, well, there's no real risk in, it's very difficult to stratify. And then people say, well, you just can't predict it, it's just too unpredictable. My point here is that, well, for clinicians, I mean, there is some research to show, this is a systematic review, which if you ask clinicians to try and classify people into high and low risk, it's not very accurate actually. So the sensitivity, which is the number of people that died, how many of them were identified as high risk, well, it's 31%. So that means a lot of false negatives. So I think clinician classification was considered to be too inaccurate to be useful. And there are other studies that have shown that clinicians and tools are actually very similar to each other. So the tools that in the past haven't really added much. And this is another way of testing performance of a tool. It's called area under the curve. And it's an omnibus measure that looks at tools at different thresholds. And I won't go into the details of this, just really to point out that they are similar. The Manchester self-harm rule is similar to the clinician global scale or global rating. But I think people in the field have highlighted some problems, and I think these problems are entirely justified. And I think the problems are that these tools have been developed for different outcomes. They haven't been validated properly for suicide outcomes. Often they merge self-harm and suicide, or sometimes use other markers like suicide ideation. And the classification metrics, like we've discussed, aren't particularly great. Lots of false positives are highlighted, and there are other things that are highlighted. And most suicide deaths are happening in the low-risk group, which people talk about as the sort of prevention paradox, that if you just focus on high-risk people, you're missing the most people who die, because the numbers are much larger in the low-risk group overall, and also when it comes to suicide deaths. So I think these are entirely justified, but they are based on these tools, which here's a list of some of the tools, and what's important is to look at the outcome for their original development. So tools such as the Beck Hopelessness Scale were developed to measure hopelessness symptoms. The Beck Depression Inventory was depression symptoms. The scale for suicide ideation was for suicide ideation at the point in which you're doing the assessment. It wasn't a prognostic tool. The same applies to the Beck Suicide Intent Scale. It's not a prognostic tool, it's a rating scale for here and now. And so actually these tools aren't developed for the purposes which they're used, and I think it's right that guidelines and other articles have pointed this out and discouraged their use. But the idea that suicide isn't protected isn't borne out by the evidence. So here's a study we did. It's in a high-risk population, so it's in people with severe mental illness. And what it does is we followed everyone who was diagnosed with schizophrenia, spectrum disorders and bipolar disorder up for a year after an assessment either done in outpatients or inpatients, randomly selected assessment of everyone who had a diagnosis. And we followed them up for a year for suicide deaths. And this graph shows on the y-axis the observed number of deaths versus what we predicted to be the case based on a simple scalable model we developed called OXMIS. And you can see actually that the prediction is actually quite accurate, particularly at the lower end of the scores, so where it's about 1% or 2%, the prediction is very accurate. So it's not actually true that suicide can't be predicted as a blanket statement over 1 year, and using an empirically developed risk model in a high-risk population, it can be predicted. Not perfectly, but it can be predicted pretty accurately. I mean, this is considered quite good in terms of calibration of a tool. And we've done the same more recently for another tool we developed called OXATS, which is for people who've presented with self-harm, followed up for suicide. And again, it's got a graph showing the predicted probabilities versus the observed probabilities. And again, it's they're quite close to each other, the predicted and observed. They're not perfect, but they're very, very close, particularly again at the lower end of probability. And this is a probability over 6 months and 12 months. So again, prediction is unlikely to be good at shorter timescales. But if you use a timescale that I think is relevant for clinical services in terms of looking forward about management and allocating resources efficiently and in an evidence-based way, then I think prediction is possible. Another myth, I think, is that it's too rare. It's so rare that it basically makes prediction not very accurate or useful. I mean, it's partly addressed in previous slides, but I think I just mentioned the fact that if you look at the rest of medicine, you have rare outcomes like diabetes. This is cardiovascular risk in diabetes. This is in renal medicine. These are chronic kidney disease risk calculators. Respiratory medicine around respiratory diseases, risk of respiratory diseases. And a melanoma risk calculator, this is endorsed by the National Cancer Institute in the States. Melanoma risk can be very low. I mean, here's one example. So it doesn't, just because something is rare doesn't mean it's difficult to predict. And I think the weather is another example. I mean, you know, in some settings, it's actually very rare that it rains, and yet you can predict it accurately. So the fact that something is rare doesn't mean that you're not able to predict it. So I think that's a myth, actually, and not borne out by the evidence. And then finally, I think a final myth is that, well, even if the performance is what it is, it's not good enough for clinical use. Clinical use um, either requires it to be perfect, and if it isn't perfect, then you just have to treat everyone the same way. Well, I think, again, I don't agree. Depends on the clinical area and the alternatives. The idea that you can give everyone a gold standard assessment and treatment is not really realistic in some clinical settings where you have to allocate resources efficiently and in an evidence-based way. You can't assume everyone has the same level of risk going forward, let's say even based on a needs assessment. So you may well do a needs assessment and two people may have similar needs, but what you do about them will be informed by their risks going forward. So the example I gave earlier of an older man presenting with self-harm versus a younger woman, they may have similar needs, let's say, around problematic alcohol use. And the question is, would you do things differently because you know that the risk going forward in the older man is much more, is much higher than the risk in the younger woman, particularly in the case of alcohol misuse, where actually resources are quite limited, and whether you add on treatment to current treatments it will have to be a decision, I think, informed by risk, not just need. I think everyone does need a safety plan. I think it's one of the advantages of these probability tools, because everyone has a risk, everyone has a probability, and so safety planning is actually underscored by these tools. But in terms of performance, I mean, my point really would be that you just don't use one metric, don't use AUCs, calibration's important, PPV is not really relevant for probability scores, and then when it is used, have to be very careful how it's interpreted, and there are more, the more needs to be done, and there are different ways of actually looking at the clinical decisions being made and whether a tool can add to decisions, can add to what currently exists or the alternatives. And interesting enough, I mean, American groups, particularly at Harvard, have actually considered this issue, and they found that if you want to use positive predictive values in a tool that classifies people, the PPVs can be very, very low for them to be cost effective, because the cost of one person from dying from suicide is so high that even a small improvement in what's currently done will have a big impact. And there's a couple of papers where they've tried to model this. Well, one paper, and they've got a couple of PPVs there. So I'm now going to talk a little bit about work we've done, just to show where we've landed in terms of research. I think what we've done is trying to develop novel tools using really the best methods that have been developed actually in the rest of medicine, and apply them to suicide risk prediction and assessment. And there's some very simple but important methodological advances to do with using large data sets, relevant populations, pre-specifying what you want to do so to make it difficult in a way, and using a range of performance measures, not just one, and having candidate predictors and predictors generally that are easy to score, don't require extra interviewing or subjectivity, and developing calculators that are like the ones in cancer medicine or in cardiovascular medicine, that are scalable and web-based and free to use. And you can see how they're used, so it's transparent in the sense that you can see what goes into them and what effect they have. And like I said, not to use one statistic, and also think about what the comparison is, because even if you present the statistic, what is the comparison? And often I think people in this field use a gold standard, which is unrealistic, of perfection, and that's really not relevant. It should be against what currently happens. On the basis of these new methods, we've developed 2 models for suicide prediction. One is called OXMIS, which I mentioned earlier, and the other one was OXATS, which I also mentioned earlier. And you can look them up, and they're indications of, I think, the way the field can progress. What role do they have? Like I said, I think before, everyone has a risk score, so everyone needs a safety plan. I think it's important, and that will actually improve clinical management for lots of people who don't have a safety plan. And it's important in many guidelines, that it's one of the most effective interventions. And equally, I think, it does also highlight the fact that everyone needs a psychosocial assessment, because again, everyone has a risk score, and again, that's something that isn't being done currently. I think my point would be that what you do about the assessment will be informed by that risk score, and because not everyone can get everything in most healthcare systems around the world. So finally, prediction is possible. It depends what you mean. If you mean over a 6 to 1 month period in a high-risk population, it definitely is possible, and the evidence suggests that in many studies now. I think it has to be, these tools, they have a role, but they have to be embedded alongside clinical practice, and it shouldn't be just one versus the other. They work together, and they can improve assessment by improving consistency, transparency, raising the ceiling of expertise, like I said, particularly in teams where there's high numbers of staff turning over and lots of different variations in people's experience. And I think you can see them as part of a wider holistic risk management. So actually these tools are really part of the management. They're really part of the therapy in a way, because they push everyone towards having a safety plan, a needs assessment, and they can help inform how to take those forward. Thank you for your attention.